Hey doctors, in today's episode we are diving into some of the most testable and frankly memorable topics in microbiology and reproductive medicine. Sexually transmitted infections, pelvic inflammatory disease, and urinary tract infections. Whether spotting the bug behind a genital ulcer, choosing the right empiric therapy for PID, or reading a urine analysis like a pro, we have got you covered. Let's decode the buzzwords that make or break USMLE questions. Let's start with genital ulcers, a favorite for USMLE step 1. The trick: focus on two things, pain and lymphadenopathy. Here is a memory hack. Painful, remember H and C. That is herpes and chancroid. Herpes caused by HSP gives you painful vesicles or ulcers with tender inguinal nodes. On smear, you will spot multinucleated giant cells, and this is classic. And then chancroid, caused by Haemophilus ducreyi, also presents as painful ragged ulcer with painful suppurative nodes. The buzzword here is school of fish appearance on gram stain. Now, the painless ulcers. These are sneaky. Syphilis comes with a clean, painless chancre and painless nodes. It is confirmed with VDRL or RPR followed by FTA ABS. And then comes LGV caused by chlamydia. L1 through L3 start with the painless ulcer, but you will later get painful lymphadenitis, often with a groove sign. Donovanosis, though rare, causes a beefy red painless ulcer. If you see Donovan bodies in the macrophages, and that's a giveaway, it is Klebsiella granulomatous. Now on to PID or pelvic inflammatory disease, and this is a classic step 1 setup. Young women, lower abdominal pain, cervical motion tenderness, and that's a famous Chandelier sign. The most common bugs here is Chlamydia trachomatis and Neisseria gonorrhea, and treatment is ceftriaxone plus doxycycline, and if there is any suspicion of a tubo-ovarian abscess, always add metronidazole to cover the anaerobes. Don't forget Fitzhugh-Curtis syndrome, a complication of PID where inflammation spreads to the liver capsule. You will see valence string adhesions on laparoscopy. It's a favorite step 1 image based question. And now we swing to urinary tract infections, UTIs. If it's a healthy young woman, suspect E. coli and sometimes Staph saprophyticus. If a sexually active persons, think E. coli is the king, but saprophyticus hangs around too. If catheterized patients, watch for Proteus, Pseudomonas and Enterococcus alongside E. coli. And don't forget, pregnant women are always screened and treated even if asymptomatic to prevent pyelonephritis. Diagnostic clues make a huge difference. If there is leukocyte esterase on the urine test, that tells you there are white cells in the urine, which is a sign of inflammation. If nitrites are positive, gram-negative bacteria like E. coli are the culprit. And if you see WBC cast, that means the infection has reached the kidneys. So now we are talking about pyelonephritis, not just cystitis. One more USMLE trick. If a patient has dysuria, positive nitrites and no vaginal symptoms, and that is E. coli UTI, until proven otherwise. And if you ever see alkaline urine in a UTI setting, think of Proteus, which is urease positive and can form struvite stones. Let's wrap it all up with a few high yield buzzwords. Strawberry cervix screams trichomoniasis, Donovan bodies, Klebsiella granulomatous, painless ulcers with lymphadenopathy, think syphilis, painful ragged ulcers with nodes, go with chancroid, WBC cast, think of renal involvement in UTI. A quick recap. Painful ulcers, remember HSV and chancroid. Painless, remember syphilis, LGV, and donovanosis. PID is mostly from chlamydia and gonorrhea, and always cover anaerobes if abscess is suspected. For UTIs, remember E. coli and cast for pyelonephritis. You just navigated through some of the most exam heavy infections, and now you are ready to spot those buzzwords in a heartbeat. You have got this. Keep that energy going, and I will see you next episode. This is Dr. Ram here from MedMadness. Thank you so much.